not biopsy is okay. Should I biopsy this or not, or should I refer this over? I'm going to cover this through a couple different things that have been actually like proven through a lot of statistical studies, and I'll go over an algorithm that should be quite helpful. And I can even share this presentation because I think this presentation alone, I made it in such a way that you would be able to actually review and learn from it down the road. I guess I'm going to say got it to this and then continue on. Okay. So I already asked you guys this. So talking about just what a dermatoscope is, I think often a lot of people are like, what the heck is that? How does it even work? So the idea is it only magnifies what you're looking at for whatever the neoplasm, the skin lesion is, whatever, by 10. So that's really not a lot. A lot of eye loops that you use for like jewelry magnify up to 20x and sometimes 10x. So it's not like we're actually getting super close, but it more has to do with like the polarized light. And I'm just going to put this in there because I know Dr. Davies said she was wanting to buy one. And I could honestly give you a good review of what ones to buy down the road, but you need to get one that's polarized. If you're getting a non-polarized dermatoscope, they're useless. It's not doing it at all for what it's intended to. So the way that it works, that looks like it populated funny into the slide. So I'm just going to adjust it. Anyways, the way that a dermatoscope works is essentially you have light coming in from the light source, which is over here to the side, which is weird. But it's on top at this area, you have a polarized light that goes down. The polarized light allows it to go down into the dermal layer and reflect the light beams around, and everything that has light hit it should reflect it back. And so polarized light allows us to see underneath into like the dermal layer. So when it comes back up to reflect the light, it goes through the lens of the dermatoscope, and it does this thing where it's supposed to scatter it and make it so there's not as much as a reflection. And so if you were to look at a lot of lesions with non-polarized light, it would just kind of make like a white glare. It would be hard to see. It's almost kind of like when you take a picture with the flash and it makes everything too bright. Polarized light allows you to essentially see under, so you can start to see more deeper structures. And so again, if you're not using a polarized light, you're just looking at something a little bit closer. I will admit it surprises me that these cost over $1,000 for something to give polarized light, when I don't think that's probably too expensive. But that being said, in order to have it actually give you what you want, you need to get the ones that would be correct. Briefly, it's really odd because you'll go and you'll look at all these videos of people using dermatoscopes, and they'll say, yeah, you got to use a clear gel, or you got to put on like dermoscopy gel in order for the lesion or whatever you're looking at to be seen better. And all the dermatology offices where I've rotated at, they place them on there and they go to town just looking. Now, obviously, if you had a very concerning one, you could throw on a bit of the gel. You could put on, I'm assuming you could, I've never tried it, but if you did like a clear type of ultrasound gel, one thing that I have done, and I see a lot of dermatologists do, is they just get it kind of wet using an alcohol wipe. It helps bring off maybe some of the crusting and scales in certain lesions. But for the most part, you put it on there. Oh, and I was going to hold one up. The big thing is they have these viewing type of lenses, and the viewing lenses, you just rotate it. And again, I don't know if you guys have used them, but some of the big things that you're wanting to do when you start to go through it is you want to get one that has a very nice sized like an eye spot to look through. So you hover over the lesion, you rotate it in and out, you light it up, rotate in and out until it comes in there. The snap a picture and save it in the EMR. Not all of them go onto a camera, but you can put a camera right onto it. I think it's a really good way. I try to, anytime I use one of these specifically in clinic, put a picture on there. And maybe nobody down the road will do it. You see that picture from my patients that they follow up on me after me, but it definitely helps me feel better about what I'm viewing. It also forces me to try and describe what dermatoscopic findings I have, and hopefully that can maybe be passed on to like a dermatologist that needs to review it. And if not, it at least practices my skills. So that's just a side thing I try to do because our EMR is really easy to get into and do that. So I'm not going to ask if anybody's had any experiences with it. I want to make sure I get into the content of it. Here's a study that they showed. I got a lot of chat and stuff pulled up on mine. So what's interesting, this is for melanoma alone. So and again, take this with a grain of salt. This study was conducted in dermatologists, not family medicine doctors, but I'm going to show you some down the road where family med doctors are doing it. So again, dermoscopy is probably only as good as you are comfortable with it and know how to do it. But so when they did in this study, so visual inspection alone versus visual inspection with dermoscopy, it's obvious to see that your sensitivity and your specificity went up. What I think is really cool is like, look at the false positive rate of visual inspections alone. I don't know if maybe that's because the people were concerned. Was there an anchoring bias? Because they're like, oh, abnormal pigmented lesion. I don't want to be wrong. Either way, much higher false positive rate, which isn't bad. Like, did that cut out?
You cut out briefly, but now it seems that you're back.
Okay. So again, using the both of these two, we lower our false positive rates. And then we also have a more true positive, less false negative, better outcomes. So here's some things that they've done as far as studies using family med doctors. Some of these had residents involved in them and even just medical students. So obviously the incidence of melanoma and non-melanomas cancers, they're increasing across all of Europe, North America. Great. That's probably not a super huge surprise. So in one of these studies they had, there was a 76 reduction of the number of unnecessary surgical procedures performed by primary care providers trained using dermoscopy. And there's a test that we'll go down to, or a study they did where these were physicians, when we talk about the TADA algorithm, they were only given 2 hours worth of training and they had great outcomes. So other things is dermoscopy helps in unneeded biopsy. And then the last thing is the American Academy of Family Physicians recommends curriculum guidelines for us as family residents to have training as part of it with dermoscopy. So including dermoscopy training as some of our skills. I don't think that's too unreasonable, given that there's so many sources that we can use to do this. And I mean, it's kind of fun. So that is a pretty big driving force for me. So let's see, I was going to call out specifically on people that are logged on and have them answer this, but the fact that I don't see faces, I don't want to embarrass them because maybe they're logged on, but also precepting or other things. But if somebody were to have, if they feel comfortable, if somebody walks in and they're like, hey, look at this growth on my arm, it's brown and it's been there for a couple of years and it's getting bigger. How do you guys look at it? Does anybody feel comfortable telling me what they would do to assess that lesion? Hey, Dr. Pennings.
Hey, I would get a little bit of history about the lesion when they first noticed it. Is it something that's been there for birth? Is it something that's kind of come up more recently? And how has it changed? And then I would get a little history on like family history of any sort of skin malignancies. And then in terms of looking at the lesion, I do use like that ABCDE, like whatever approach.
Yeah.
So I'm looking at the size of the lesion, any asymmetry, what the border looks like, what the color looks like. Is there different color patterns that are concerning to me? And then from there, like we have dermoscopy here. I'm not an expert in dermoscopy, but I kind of know some of the things that you're looking for in terms of like weird mosaicism of the pigmentation that might be concerning. If there's like pigmentation that's straying outside of the border or what you would describe as the border of the lesion, all those kind of things to help kind of risk stratify it. And then I have a low threshold to just to biopsy anything like right there on the spot. Just doing a shape biopsy and sending it off just because it's really quick to do and get the pathology back.
Okay, that's perfect. Do you know what are you familiar with what the TADA algorithm is for dermoscopy?
I haven't used that, no.
Okay, well, because you actually just stole my thunder of where this is ultimately going to go, but you described it actually in a perfect way. So I would only echo, I won't even repeat what Dr. Pennings just said, because that was actually like the perfect way, I think, to assess a lesion. And so what I want to do is, with what he already described, I want to go over a couple very simple key things that, as Dr. Pennings was saying, you throw on a dermoscopy, and this is going to help you assess whether you should biopsy or not. So my first question is, Megan, because I saw you're on there, I have a question. Here's something abnormal looking. What do you think it is? Maybe Megan left. Houston, can I call you out? Can you tell me what you think this is? Well, maybe the call out method won't
I'm
work.
just sorry, I just joined in.
What is this?
Like, am I supposed to know the answer to this?
I don't know. What do you think it is?
It is it's one of those like psychiatry blot stains.
Okay.
It looks
Isn't that
like
what you're
a beaver skin.
beaver skin. Okay. Dr. Davies, do you think this is a beaver skin?
No, that's definitely a beetle.
A beetle. Okay. Let's see. Renee Thompson, what is this?
That's a frog.
That's a frog. Okay. I thought it looked more like a butterfly, but that's fine.
The pelvis with the
It's a
sacrum.
pelvis. It is a pelvis. It does kind of look like that.
The sacrum and yeah.
What's this, Liz? And maybe she left.
Upside down,
Come on.
upside down wolf or a moth on a
I
wall.
think that would work. It also looks like a stormtrooper from Star Wars. So, I mean, so the reason I say this is like, honestly, anybody could look at these things and have very much disagreement of what they're looking at. What if I said this? Would anybody here argue this is an elephant? Probably not. And then I'd say, well, why do you say it's an elephant? It's like, well, geez, it has huge ears. It has a very specific trunk. It has 4 legs. That's not as specific. I mean, all mammals should have 4 extremities, right? But when we look at this elephant, we know that it has very specific features that clue us in to know it is an elephant. And so dermoscopy is the same idea. When we look at, when we use a dermatoscope, we're looking at it in this magnified lens, and we're looking for specific features that would make us start off by saying, okay, this is X type of diagnosis. From there, I know it's that based upon these features. So jumping onto a couple of things, there's called the 2-step algorithm, which is what I originally learned with, which is we take a look as, is this a melanocytic type of lesion? Is it not? That type of learning algorithm takes a lot more upfront training. And I think it's probably a little bit more geared towards like dermatology. And in hindsight, had I known there'd been other ways, 3 years ago, I wouldn't have started with it, but I will say it's added a lot of good education to my base. But recently, when I went to an AFP skins and procedures type of conference, they are now really strongly incorporating and recommending this TADA algorithm, which is on the right side. And TADA stands for Triage Amalgamated Dermatoscope Algorithm. And the amalgamated means like we've taken 5 different types of way we assess a lesion and shove them into one. But the whole point of this algorithm is for us to say, do we biopsy something? Do we refer it or do we watch it? And so I'm going to talk about a couple of those things. So real quickly, the sensitivity for the first step, and we're talking about, well, I'm going to skip the 2-step because I don't want to waste time on that one. So going to the TADA algorithm. So they took a bunch of like residents, dermatology first-year residents, family medicine residents, and medicine students, gave them some basic training, and they evaluated 50 polarized imaging, went through, and it says most dermatologists, primary care, and in some of it too, they had med students, and they had lacked no really prior training of dermoscopy. But they found that using this algorithm, this TADA, that the sensitivity and the specificity for the skin cancer was 94% for sensitivity, and specificity was 72%. So when we think about sensitivity, we want something that's very good at ruling in or out. So snout, sensitivity rules out. 94% sensitivity using this algorithm, meaning, do we feel comfortable or not if this is a concerning lesion? And I think once you get the hang of it, it actually flows pretty quickly, but a lot of it takes practice. I think the best way to do this type of teaching we're doing right now is I'd love us to, if we could have had a couple of few things we discussed, and then everybody grab a dermatoscope and just start looking at moles on their arms and faces and legs and everything. So again, the big thing we look for when we talk about TADA is actually what a little bit what Dr. Penning said. Big things are disorganized versus organized. Does the lesion have abnormal findings, does it look off balanced or does it look, I don't want to use the word symmetrical because cancers can learn symmetrical and the TADA does not look at symmetrical under the dermatoscope. Now, symmetrical versus asymmetrical means a lot of things when you look at it grossly, but on the TADA, that's not part of it. So we're looking at disorganized versus organized, chaos and clues, meaning very abnormal structures or findings. And again, that's where it's going to take us down the step. So I think if we were to just look at the TADA algorithm, it would be a little bit confusing. And so I want to go over benign moles. I think there's a study that they were saying like 85% of the lesions we look at are benign nevi, whatever it was. And again, and that's me trying to remember that thing I'd come across reading, but most things that we look at are probably going to be benign. So it's good to know what the benign patterns are. So here's a nevus on a 13-year-old kid or whatever. We're looking at this. Grossly, it looks pretty good. Dermatoscopically, does this look good? So we know it's pigmented. Nevi in general, well, all nevi should be pigmented. If it's not pigmented, then it's not a nevus, it's something else. So they all have a network, and there's different types of network that on the dermatoscope you're going to see. And this overall has a symmetrical pattern. Here's the, what is there here, 12 or 11 symmetrical patterns that you'll see on nevi that are considered benign. And at first you're like, well, what the heck is this supposed to be? This is a really helpful page to remember. And so what I did when I got my first dermatoscope 2 years ago, I actually had this up and I started going to family reunions, just asking to see people's moles. And then I'd look at their mole and then I'd look at that and be like, what pattern is that? And I mean, maybe it made them uncomfortable. I don't know. But I found it was really good to put myself to the challenge to say, like, what am I actually seeing? And can I identify these structures? So a diffuse reticular pattern. So this goes by diffuse network or diffuse reticular. When you look at this, it looks like a meshwork, like somebody laid down a net. This is an absolutely benign pattern. So if you were to put this on somebody's abnormal growing mole and you saw that, you should feel comfortable saying benign. So this is what it looked like grossly, you know, at large. Somebody might say, look at those. I don't know, is that symmetrical? If I folded that in half, would that look like it was asymmetrical? But when you look at it on the dermatoscope, this has features all consistent with the benign pattern, diffuse reticular going throughout, or diffuse network. This one's patchy network. The studies show that, yeah, if you look at this and see this, it's going to be a benign. This might make people a little uncomfortable because is that actually a loss of network would be concerning for melanoma? But again, this is a diffuse patchy network. So echoing what Dr. Penning said, when he said I'd ask them about their history, if someone's like, that mole, and say grossly, they said it's not changed. I've had it for 40 years. And I looked at it on the dermatoscope and I'm like, you're trying to tell me this thing's never changed. And when I look at it here, all I see is a diffuse patchy network. I'd be like, great, benign. There's another image of a diffuse patchy network type of finding. Here's a very common one until you start throwing a dermatoscope on it. This has a peripheral network, which it also has small globules. I would add that in there, but it has central hypopigmentation. Here's the reverse of that. It has a peripheral network pattern with central hyperpigmentation. So if somebody say, I've had this forever, it's not changing, I'd be like, great, this fits the benign pattern. Here's ones that I think I'm not going to talk about because I think most people would sit there and be like, oh, it's a blue nevus. This would make me uncomfortable. These are ones that have been proven through like the studies that yes, the homogeneous type are benign, but I would probably say for all intents and purposes, biopsy, refer, get a second opinion. Here's a blue nevus, that's blue pigmentation. Here's one that's called peripheral globules. You can see on the periphery, there's globules all present throughout. It's actually the same process for a starburst nevus, the growing type of pattern. We'll go on for that one. So here's one called the reticuloglobular. So these center globules, for lack of a better term, are just like a big, I call them kind of like ink spots, but the globules themselves are a reassuring finding. So that very original picture I showed you was an all globular pattern. Here's reticular globular, meaning there's reticular type of network on the outside, and then globular on the center. Globular patterns, I don't have any studies to tell you, but I feel like most time I look at people's moles, it's globular. I have a mole on my right arm right here. Whenever I'm like, what's a benign nevus again? And I'll go and I'll throw my dermatoscope on it and I'll look over and I'm like, because I've had this mole, I remember since the age I was like 3, and it's got a bunch of globules. Globules are a benign pattern. Here's a 2-component, which might make people maybe feel uncomfortable. You know, are these globules new? But again, 2-component with the top being reticular or network is a benign thing. This one I think is pretty hard. Multi-component. It says it always needs context, especially if it's like congenital nevus in this case. Some of these slides that I got, I talked to the doctor that actually made them, and he's like, you know, how do we know that that's actually a benign nevus? Well, it's because I was concerned about it. I biopsied it, and that's how I know it's a benign nevus. So that's something that was biopsied there. The question I would have is, how comfortable would they feel saying, no, that is a benign pattern? Let's see. Somebody that's not Megan in the IM call room, are you able to see this lesion, this pigmented lesion? And if so, are you able to tell me what it is? Can you tell me the pattern from our brief review?
Is this the reticular network?
Yep, nailed it. That's it. Okay, great. It's benign. What about this one? Anybody yell out if they feel comfortable. Now, this one didn't get covered, but there's 2 components here. This is called cobblestones, which is a benign pattern. And then the rest, which would be globules. This one didn't upload super nice, but that has a globular pattern with peripheral globules. This is that central hypopigmentation with a diffuse reticular peripheral pattern. Let's see, does anyone want to take a stab at this? They sure don't upload as nice. They look clear now on my side here. Let's see, I don't know who Erwin JS is. Do you care taking a stab at that? And if you don't, you can just give me a thumbs down or something. So that is globular, great. So this here, lastly, the starburst pattern. Starbursts are considered benign. They have like this type of pseudopod appearance, which we're going to go back to when we talk on melanoma. But if you think of a starburst, it's bursting out and 50% of it should be present, that pattern, in a nevus. If it doesn't have a starburst appearance of greater than 50%, I would recommend biopsying, and we're going to talk about that when we go on to melanomas. So here's where the big thing comes into when we're talking about the TADA algorithm. So somebody has something of concern, you see something of concern. What we're going to do is, 1, say, is this an unequivocal lesion? Meaning, I have no doubt in my mind that this is not a cancer or a nevus. I think it's either these 3 patterns, which we're going to go over here really quickly, or I think it's something else. So I know that maybe sounds confusing, but the first thing to say is it a dermatofibroma? Is it a subarachnoid keratosis, or is it an angioma, hemangioma? And if yes, you're done. If not, we then go into this algorithm. And these first 3, I think this is really easy, because the goal of this algorithm is not to diagnose a lesion. It's to say, do I biopsy this or do I not biopsy it? And again, that's the really important thing to remember. Watch and wait, reassurance, or refer or biopsy. So if something comes up that we're concerned about, the first thing that we're going to see is a couple things that we would want to question. So here's the unequivocal lesion. Is this an angioma? I hope most people at large would feel like, yeah, that looks like an angioma, but on dermoscopy, it has very specific findings. For dermatofibromas on dermoscopy, very specific findings, and then subarachnoid keratosis, very specific findings. You could probably argue I don't need a dermatoscope to confirm any of what we're about to see. But when we pull these up, we're going to see that there's very specific lesions. It's pretty awesome when you throw a dermatoscope on somebody's angioma and see this. So this is what we call septa and luna. So septa and luna, we'll go over those things. And then next to this is the angiokeratoma. So lacunae and white septa or septae. I don't know if I'm saying that correctly, but septa, septae. We'll go into those things. So we have a red colored lesion here, and we have those findings. So here's the septae, which is these inner type of spaces. I guess to me, I think of it, whoops, last time I did this, it didn't go backwards. Good, there it did. I think of it as like the more lighter white type of, I guess in my mind, I've never looked at what that would be on like histology, but like this interconnective tissue, because we know that this is this is a group of arteries, kind of like a nevus, but a group of arteries, not the melanocytes, but the arteries. And then the lacunae, which are lakes of arteries. That's why it has that appearance. So you're like, great, this is totally an angioma. We just watch this do nothing. Here's a dermatofibroma. It has very specific features. It's going to be common on the lower extremities. I guess I'm going to have to keep on like quizzing my attendings who I'm seeing on here, but does anybody know what this sign is called? And if you don't, it's cool. This is a pretty good cheat sign to use if you didn't have a dermatoscope, but this is called a dimple sign. You essentially squeeze it, and when you do that, it'll cause a bit of this umbilicus or central dimpling in. But when we look at this on a dermatoscope, there's going to be some features that come up here that have very specific findings. So if you see here, we have like a central white patch. You'll have fine vessels, and then those are those dotted vessels. But I think of like this area here, and does it show my cursor good? Right there's the scar tissue that you would see. And then you can have a delicate reticular pattern, which is seen up here. So like on dermoscopy, everything about this looks just like a dermatofibroma. And if its clinical kind of gross appearance is a dermatofibroma, you can reassure. I think it's really important to get good at recognizing seborrheic keratosis because, you know, those start to come on in the 5th decade of life and on. And there's so many features they have. And with a dermatoscope, you can feel really good about saying this is benign. Now, obviously, a big stuck-on lesion is going to be super obvious for us SK. But when you throw this thing underneath a dermatoscope, there's some stuff that just kind of pop and come to life. So milia cysts, there's these plug little portions of it where they have these milia cysts. What's super cool is this is where the dermatoscope, when you turn it on, you can flash it. Depending on its features, if you hit a button, right there, this one I'm holding up just went to non-polarized, polarized, non-polarized, polarized. Those milia-like cysts will actually specifically reflect at you, and you'll get this flashing sign going back and forth that those milia cysts will shine and come to life and be like, yeah, those are milia-like cysts. That's what we see in SKs. They also have these comedal-like opening, which are those just black plugs. I don't know what you want to call them, but those black thickened areas. And then this is the one where they start to kind of have like that cerebriform pattern, like a brain, what is C. They're pretty specific, and it can help you feel really comfortable about diagnosing an SK and watching it. You can freeze off an SK with cryotherapy. Takes a good couple things, but yeah, it's a benign lesion. So here's that thing I was referring to about non-polarized with polarized light. So here's polarized, those milia cysts don't really pop. Then you turn it to non-polarized and they stand out. Kind of cool. There's the cerebriform pattern. It looks kind of like whatever that little type of coral thing is. You can feel really comfortable saying like, you have an SK, great. Here's one that's called a fingerprint pattern. This looks almost as if it's had a form of somebody's fingerprints. Common. The other thing that they talk a lot about in SKs is these moth-eaten borders. So it's like a moth came and took bites out of it. You can see these sharp, well-demarcated borders, reassuring for an SK. Again, this has some really good features of fingerprint pattern and then sharp, well-demarcated borders, all reassuring. So now we have this next thing come up. So we're going down this TADA algorithm. And somebody's like, hey, doctor, look at this thing on my back. And you're like, oh, okay, that does not look like those first 3 lesions I would see. So you could stop right there. You could say, is this unequivocally an angioma, an SK, or dermatofibroma? Well, if you were to say no, where the algorithm takes you down to, if it were to be yes, you'd watch. If it takes you down this side, you'd say no. The next step is you could just most reasonably biopsy it and be done. Biopsy and send it on. Does anybody know what that is by looking at it? And I promise you, after you do a little bit of practice, this thing will like scream a couple things to you. So this is a BCC, basal cell carcinoma. So you could just sit there and be like, great, it's not fitting those patterns, biopsy it. It came back as a BCC, you set them up for whatever you want to do next for management. But instead you're like, no, I don't want to just go cut on somebody. I want to make sure I'm addressing this. So then we go into our next part of the algorithm. So now we're going to say, does this have any asymmetrical distributions, colors, or structures? And these are all essentially relating to forms of cancer. So say you're like, yeah, it does. Look at this lesion. There's no lack. It's very asymmetrical. There's abnormal colors. There's these odd findings. So you biopsied it. But maybe we're saying, like, I don't know. I don't feel super good. I'm not that well trained at this. I felt like if I folded this in half, it would kind of match on each other. So you're like, no, I think this is symmetrical. It then takes you down to this next step of the algorithm, which these are all specific cancer findings. Are there streaks, starburst pattern on the periphery, negative network, vessels or ulcerations? If you answered yes, then great. Biopsy or refer. Is it blue, black, gray, or has these white shiny structures? If you answered yes, great, biopsy. If you say no to all of this, this would take you back to our benign nevi patterns. And so this is why in the TADA algorithm, you don't have to learn nevi patterns. And if I were to show up a picture of a nevus, you could sit there and be like, oh, okay, I see how this gets to the end of that. But again, this is going on. So here's where we go on to talk about like this disorganized or chaotic. I would hope, regardless of any training, that if somebody threw a dermatoscope on that, they would probably think that looks bad and biopsy it. I mean, so in some ways, I don't think you need, this is why I think the TADA algorithm is so nice. It's either those 3 benign patterns, or if it looks really abnormal and chaotic, biopsy it. That's the point of why they recommend this for primary care doctors. So again, here we see something that's organized. Here we see something really disorganized. This is a basal cell carcinoma, biopsy it and move on. Moving on. So when we take a look at a basal cell carcinoma, the most important thing to remember, most common skin cancer is going to be a basal cell carcinoma. 80% of non-melanoma skin cancers are BCCs, and I did a triple C, so that's for basal cell carcinomas that are cool. And 80% of non-melanoma skin cancers are BCCs. So I think it's pretty cool to get good at learning what these least are, because they have some really funny sounding features that once you start to see them, you'll be like, oh, I got it. So this is where that telangiectasia, those arborizing vessels, these are called leaf-like areas. So if you were to kind of zoom in close on them, you would see they kind of have that ferning leaf-like look. Another very specific one are these ovoid nests, kind of like these eggs inside of a nest. This has very much hallmark findings of an ovoid nest. And here's arborizing vessels. Here's actually what they call those white shiny structures. What I think is funny about dermoscopy is it's like, who made up these nests, or these names? They kind of just found some like kind of interesting, like very obvious type of findings, and then they threw them to this, because really, what's so hard to think about an ovoid nest other than it's this blue type of structure and it's ovoid shaped? Great. This ones I think are super cool. These are called spoke wheel structures. If you look at these, you can see the spoke wheel structure. So for example, if you look here, you see the spoke-like wheel structure. It's central hyperpigmentation with these kind of strands coming off. This is pathognomonic for a BCC. There's your, this is in a, like a arborizing vessel, your telangiectasia that you learned about. There's your ovoid nest. And this has arborizing vessels. Here's your white shiny structures. I would probably say maybe that could be called either a leaf-like structure, but again, this has all of your features. That's a BCC. When I finally started to get a little bit better at dermoscopy, I was at a dermatologist's office, and I'd done a little bit of dermoscopy training, and I remember I saw this abnormal lesion, and I was like, it just kicked something in my gut. I was like, that thing looks so weird. And looking at it now, I wasn't new and I was new enough I couldn't remember the term, but it had ovoid nests and a spoke-like structure. And I remember I snapped a picture of it and I went and showed it to the dermatologist because he was having me around on the patients first. I was like, this thing looks really odd. I can't remember what these are called. And he's like, oh, hey, you just caught a BCC. Great job. Let's go remove that right now. And I remember thinking like, it just rang a bell in my mind, seeing those structures. But the features were faint enough that like initially, who knows as a PCP, would I've actually stopped and looked at it, or I feel like with the training, it caused a lot of this like reflex action, like there's something abnormal. This doesn't seem right. Here's some proven studies about leaf-like structures has 100% specificity for being a BCC. Spoke wheel-like structures, 100% specificity. You find this on dermoscopy and its specificity is 100%. There's not a lot of tests in medicine where you have like 100% specificity that I'm well aware of. That's why I think it's kind of cool. Like, great, spend some time learning about BCCs and its dermoscopy findings. It's gonna be your most common skin cancer when you're starting to get up into the ages of 70 plus, 50, 60, 70 plus, and you're gonna be trained well enough to catch these. Jumping over to like melanoma specific patterns. I'm going to kind of fly through this because we're running out of time. But when we talked about the pseudopods, if you see this outside edge, it's kind of like somebody smushed a little bit of like the melanin, and it's just kind of like streaming out. Probably most people grossly would say this looks abnormal. I'm going to shave it or do a punch depending on its size. This you can look at. Right here is called that they call it like a blue-gray, not like a blue-gray haze, but it has a term, milky red areas. I'm trying to find what the more specific, but so like we have the shiny white lines, which can be seen in this area here, but also that like blue-gray haze. So this has like the pseudopod edging. It's kind of smashed. It's not greater than 50%, which is what you would see in like a Spitz nevus. And so, yeah, biopsy this. It also has negative pigment network, so loss of area. So right there's a loss of an area where you think you would see it. Melanoma, here's a really good, the blue-white veil, that's what I was trying to say. Right, here's a really good example. On polarized light, this thing, because there's like buildup of the thickened cornified layer of epidermis, when you put that polarized light on there, it can't shoot through that blue-white veil. It's a melanoma. Great. You could also argue here that the peripheral streaking is concerning. Grossly, this picture, it probably looked atypical to begin with. Other findings that you have, atypical dots. They also refer to this as that like buckshot pattern. But this is a melanoma. You know, would you have thought this is a melanoma? You could almost say this was like a BCC. But again, this has those features, shiny white structures, atypical dots, and globules. SCCs are a really good common one that you'll start to see. They have like these glomerular vessels on the outside, the hairpin vessels. If you were to zoom in close, you would see they have that hairpin shape. The coolest ones are these rosettes. They have that little rosette-like shape. And I remember the first time I saw one of these a year ago on somebody, I was like, whoa, you can actually see them. And it's neat to catch that. So I'm going to kind of blow through this because if you guys want to learn these patterns, great. I'll show you some stuff at the end. But here we can see, so going through other very specific ones I want to say are the keratin pearls and white circles. So right here, you see all these keratin pearls, the ulceration, great. You'd also see that in a BCC. Does this have any other features? The white circles are the big ones there, the keratin pearls. Look at this one. This was a new growth in a 70-year-old female. When they looked at it, it has the moth-eaten scallop borders, which not to be confused with SK that has moth-eaten borders, but SKs are not going to have these rosettes that light up on polarized lights. Shave it and then, you know, go accordingly. I don't know. I don't think there's probably a lot of us, and I've already picked on a lot of people. I was going to actually have us try and put into practice what we're seeing here. Oh, I didn't see that question come up. I'm sorry, whoever said that, PV. Thank you. Philip. You said lower on the algorithm, it marks starburst present is a lesion to biopsy, but when you go over the benign structures, you talked about that. That is confusing, and I'm actually glad you brought that up because yes. So the recommendation is probably for most primary care doctors, you should get a second opinion on a starburst pattern, or you probably should just biopsy it. When I talked to a dermatologist, he'd said, I can't tell you how many times I biopsied a starburst pattern, but I think some of what's on there for completeness sake is yes, a starburst pattern, true Spitz nevus, that's a benign nevus. It's not a cancer. But the question is, when you look at melanomas also have that starburst pattern, but they're not going to be there. They should not be over 50% of a lesion that's symmetrical. So that's a good question for Philip, which is why in that pattern, they would say probably biopsy it. Or when we look at this algorithm, which this is a really clean version of it, part of that algorithm is we refer. So you don't always have to biopsy. So again, if I can kind of sum this up, because then we'll leave questions and then people can get back to clinic. The big point of when we look at the TADA algorithm is we're taking a look at, do we have an abnormal lesion, an abnormal type of nevus, whatever it is. The first thing is it unequivocally these three benign types of lesions that you can easily identify? And if the answer is yes, you watch. If the answer is no, can you break it down into, so right here, a specific cancer-like structure? So these are supposed to be ruling us in for cancer. And if it has cancer-specific findings, so like right there, spoke-like wheels, there's rosettes on an SCC. This is supposed to be a melanoma with loss of network. If it falls into that, and you can say yes, you biopsy or refer. If it doesn't meet any of those patterns, you then come to here and say no. Is it one of these things that I can reassure and monitor being a nevus, or again, it has vessels, ulcerations, or these blue, black, gray structures being a homogeneous nevus, etc., that I don't feel comfortable about? I'm going to biopsy it or I'm going to refer. The one thing I'd recommend, so there's two dermatologists that I've made really good friends with. And it's like, look, if I ever just get a really weird lesion, can I snap a shot of it on a dermatoscope and just send it to you? Can I get the patient's permission, send it to you, and just kind of get your thoughts? I feel like the TADA algorithm allows for, if there's something you think you can refer in the sense of like, let me just get a second opinion from my buddy who's a full-on dermatologist. It allows for that. And I've actually had quite a few things in clinic where I send it to them and they get back sometimes within minutes and they're like, yeah, that's abnormal. They're like, no, this has reassuring features. Now, again, if you don't have all those, resources, you can always biopsy using a proven algorithm, or you can refer to the dermatologist. I wanted to go through and practice cases, but I don't think we have time. I think at this point, I'll just kind of leave things open for questions or concerns or anything anybody had to say.
Thank you so much, Dr. Hawker. And I mean, just depending on questions, you do have 14 minutes, so you can maybe have a chance to do a little bit of what you had in mind, but excellent interactive presentation. And if people want to unmute or put any questions in the chat, we can go from there.
It'd be good to go through one of the cases, Rory.
Yeah.
Time.
Yeah, let's do actually. Let me see. So if you were to take a look at this, I guess we'll go through just a couple of them. And I don't know if Dr. Pennings, you want to run through them or if I should just call somebody out. But if somebody came in here and said, this is a 24-year-old female, I've been surprised when people are like, I've never seen this before. It's maybe been there a few years. So going through just the algorithm, do you think this fits the mold of a dermatofibroma, SK, or hemangioma? Does this have central scar-like area, diffuse reticulated peripheral patterns that would be in a dermatofibroma? Would you say yes or no? And I would say probably no, because it doesn't meet those. Angiomas, does this have big lacunae, big types of like like brought together blood vessels? I'd say no. Does it meet the mold of a seborrheic keratosis? Maybe. But the answer is probably no, because it doesn't have the cerebriform pattern. It doesn't have any milia-like cysts in it. When I flashed back and forth using my dermatoscope, it didn't show any like lighting. So I'd say no, this doesn't. So it's not unequivocally meaning this is absolutely one of these three things. So the next thing we would say, okay, I know it's not one of those three absolutely benign lesions. The next question is, does it have asymmetrical distribution of colors or structures? If you wanted to say, well, that's not really that symmetrical, look at that little part up here at like the 1 o'clock version. I would say from talking with specialists and doing some training on it, that yes, this is considered symmetrical because we're zoomed in. We're not just standing back. So yes, it's symmetrical. If we were to go through and study up on our cancer finding features, I don't see rosette patterns for an SCC. I don't see, maybe someone might say that's actually loss of a network pattern. You could biopsy, but let's say it's not. It doesn't fit any of these asymmetrical distributions, colors, or structures. This is otherwise a very symmetrical and evenly distributed type of lesion. Great. Does it have a starburst streaking pattern? No. Negative network? No. Does it have vessels and ulcerations? No. Does it have any of these? No. So based upon all of that, we can walk this down and say, guess what? I'm going to monitor this. I don't feel super comfortable. Let's have you back in 3 to 6 months and we'll snap another picture of it and compare. Now, that would be the way to go through this. The one reason I think it's good to kind of know benign patterns is this is all a globular type of nevus. Everything about this says globular, maybe a bit of cobblestoning in the bottom, you know, this we would call 4 to 5 o'clock position, but this is a globular nevus. Looking at this one here, if we were to go through and run through this case, boy, this like did not upload super great from my side onto yours. It looks cleaner on my laptop. I don't know if that's maybe because I'm sitting through like a St. Louis computer, but if it's blurry, this has a bunch of milia like cysts. Right there, you could say this is an SK. I don't need to do anything. This is, yes, a unequivocal lesion of an SK. Do nothing. Now this one brings up, and you can sit there and be like, is it unequivocal? No. Does it have a disorganized pattern? Well, yes, this has the blue kind of white veil structure. If you look right here, it has a bunch of pseudopoding that's not greater than 55%. Negative network, negative network. This has that distributed type of colors or patterns. We would biopsy or refer this. But again, here's the great thing about this algorithm. What if you're kind of terrible at it and you're like, no, I think that is symmetrical. I don't think that looks too atypical. And you then continue down into the algorithm. Well, just to make sure it's dummy proof, they're like, well, is there a starburst pattern? Is there a starburst pattern? Wait, there is. Okay, I guess I am going to biopsy it. Are there shiny white structures? Right, there's one. Does it have a ulceration? No. Does it have a negative network? Like, yes, there is. Right there's a negative network. Right there's a negative network. Okay, whoops, I should have biopsied this. So the TADA algorithm is really nice in saying, is this a benign lesion? Yes, great, do nothing. Is it not? Let's double check through 2 different types of patterns to make sure you haven't dropped the ball. This is a diffuse, so I would call this one central. This is a reticular pattern with some central hyperpigmentation and otherwise benign. Watch it. We don't have a whole lot more time, but like this is what I want to show you. So anybody, this is free. Go into your app and it's called Dermoscopy 2-step algorithm. And it will show you these interactive cases. When you do those cases, I promise you by the time you've gone through all those cases, you'll feel pretty good at recognizing the patterns. And you'll feel a lot more comfortable about what you're looking at. And I think have enough utility to like use the dermoscopy in your clinic. Other than that, I think this is probably a good time to stop. That way we can all get back. Yeah, it's 1:22. So other than, I guess, thanks everybody for your time. If you have any questions, you're more than happy to reach out. If you'd like to have this PowerPoint, I'm more than happy to share it. So.
Well, thank you, Dr. Hawker, so much. And if you could please just send me the PDF of this with all the pictures, the actual file will be way too large, but I will get it out with the CME certificates. I've also recorded this presentation. I know that this topic is of interest to IAFP members, so I'll make sure that it gets shared with our broad membership in full. And so that everybody remembers, please fill out the Google form if you need CME for this. I'm going to drop it back in to the chat right now. And then just a quick plug that on July 10th is our next grand rounds, and that will be from Full Circle Health Boise. Topic is TBD, but will be announced via our e-news and our other outreach soon. So thanks everybody for being here. Dr. Hawker, is there anything else you'd like to share before we close up?
Oh yeah, I was gonna preface too. This probably should have been said a lot sooner than later. This whole patterns that we looked at work for everything but on the hands and some of the features of the face for pigmented lesions. I forgot to throw that in there because they have a bit of a different pattern. So for pigmented lesions, they follow a couple different rules for hands and face. But for BCCs, SCCs, seborrheic keratosis, it's all the same rules anywhere out throughout the body.
Great. And I think everybody was still here. So we got that.
But again, if you had an SCC like this one show up on somebody's face, it still will have that rosette patterns. This one's here because of something that's found on like the hands, which is a different pattern, which is pretty advanced. So sorry, I just want to throw that out before somebody does absolutely thinking the rule applies to everything.
Excellent. Any other comments from the group? Any other quick questions? We do have time if anybody did have anything else they wanted to ask or say.
Great lecture. Rory, learned a lot. Thank you.
Yeah, thank you. Yeah, and I know people have asked, if you're going to buy a dermatoscope, you need to really make sure it can do polarized light. It's waste of your time and money if it can't.
Which one do you recommend?
So I'm not paid by anybody, but when I've talked to everybody, derm lights probably make the better ones. If you're a resident, they'll give you a pretty dang decent discount. I think I got like 30% off. I mean, it was really good, 20 or 30. And they won't give you a discount on the latest model, but like the DL4, which is this one here, is probably a good one to go with. If we go to the very beginning, I watched a bunch of videos of like which ones to get. And at first I was kind of like, oh, I'll go with the cheaper one, which I think they would work fine. Like, so this one right here is a very overall good. I think it's like the DL200. It works nice, but the thing is you want to make sure you don't get like the DL100, which has a much smaller viewing lens. And the viewing lens being like, how big is this here? When it has a small viewing lens, it makes it really hard. Like you have to get really close and go all over. But so this is the one I have here. It works great. This one is like an older model. It works great. These ones are pretty expensive. They don't give you discounts. There's only like 3 different brands that even make these. And so Dermlight, from quite a bit of extensive looking into, I felt had the best deals, the best ways to go. And it's gave you the best to go with. I actually started off with one like that clips onto your phone that I thought was cool. But the problem with it is you have to change the lens on it for it to be polarized versus non-polarized. So in use on the spot is useless, and it has a very small viewing lens. So again, probably these 3 right here are the best way to go. Although the recent most newest Dermlight has a wood lamps feature on it, so you could actually like use it to shut the lights off, and not a woods lamps, but that thing that like fluoresces green. And so you could actually do that on the spot for like abnormal rashes, but that one they won't give you a discount on.
Anything else? All right. Well, again, thank you, Dr. Hawker. Thanks everybody for joining us. Great presentation. Stay tuned for your CME within the next month, as well as the PDFs. And see you again on July 10th at the same time.
Okay, thank you, everyone.
Appreciate you all. Oh, and Dr. Jones, I just saw your chat, and it will be emailed to you, but you do need to fill out the Google form that I've shared in the chat, if that makes sense. And if you don't want CME, that's okay. Okay, you got it. All right, thanks so much. You'll be getting it soon. Appreciate it.